All right. All right. Well, we'll go ahead and get started. Thank you for attending. Um, our audience is a little light today, but we'll go ahead and record. Just so for future references, we are starting a YouTube channel, so you'll be able to go back and view all of the videos that you have missed. My name is Angie Tyree. Most of you guys already know me. I am the project coordinator for Project Peppy. And Nick Ryder, Monica Lawrence, and Dr. Larry Borsch, we all work together to make this happen. For the sake of your time, I don't want to I want to get this over before 1 o'clock so you guys can get back to work. So I'm going to go ahead and turn this over to Monica and she can get started.
Thank you so much, Angie. Okay, so let me get my screen going. All right. Does that look okay? I get the thumbs up from Dr. Ryder, so that I'm going to go ahead. So this talk, again, as Angie said, it's going to be brief, maybe 20 minutes with some time for questions, and it's a pretty practical approach to what to do with immune deficient patients. So this is implying that you've already kind of identified them as immune deficient and how to manage them. So I am going to talk to you about the treatment ladder, is what I call it, for primary immune deficiency. And this is primarily focused on the more mild immune deficiencies that patients that practitioners in the community would probably be managing. So just to get an idea of what disorders am I talking about, again, we're not going to get into the specifics of diagnosis of all of these, but these are patients kind of in the top half of this spectrum. So patients with selective IgA deficiency, IgM deficiency, mildly low IgG or IgG subclasses, specific antibody deficiency, or occasionally patients with common variable immune deficiency. So focused up here and not so much on the more severe immune deficient patients, which probably ought to be managed in conjunction with or primarily by an immunologist. Okay, so this is what I call the treatment ladder, and I'm going to go through each of these steps. So whenever I think about a patient who has an immune deficiency that's milder, I like to just force the fellows that I work with to go step by step through each of these steps to make sure that we are appropriately targeting our therapy at what actually needs to be treated, because frequently it's not the immune deficiency. So the first thing I'm going to talk about is this one, the comorbid medical conditions. So here's a case. This is the type of case that I see all the time. This is a patient that I saw very recently in the clinic as a referral. So it's a 24-year-old coming in with recurrent infections, right? So why am I always getting sick? Is there something wrong with my immune system? And when you take a history, the patient tells you they had 6 sinus infections a year. They always need antibiotics. And once they get antibiotics, they get better. They've had 2 pneumonias a year for most of their adult life. They feel tired, run down all the time. It's interfering with their ability to work and to function. They do have asthma and allergies. They take albuterol as needed, a nasal steroid spray, and Claritin. On exam, they look allergic with enlarged inferior nasal turbinates and bilateral ear effusions, but without signs of acute otitis media. Okay, so you could see how this would be a patient who, I imagine those of you who see patients in clinic probably have met this patient or someone like it before. I meet this patient all the time. So here's where I'm going to ask you is to not just stop with that history. So if you kind of dig a little bit deeper, so what are your sinus infections like? What symptoms do you have? So they actually tell you the way they know they have a sinus infection is they get this facial pain and pressure, their nose feels stuffy, right? And as long as they get their Z-Pak, they're better, right? You ask about these pneumonias. It turns out how these pneumonias were actually diagnosed at urgent care as walking pneumonias. And when you go and get those reports faxed from urgent care, there's no lobar infiltrate. It's just peribronchial cuffing. When you ask them, what did you do to take care of your walking pneumonia? And it's our Z-Pak, albuterol, and Medrol, right? So they're sort of throwing everything at it and seeing what sticks. When you ask about timing, those sinus infections and pneumonias were mostly in the spring and fall. When you ask them to show you that nasal steroid spray that they're using, it's actually saline spray, ocean spray, right? So sometimes patients think it's one thing and it's not. And the Claritin is only the pediatric dose, the 5 milligram chewable, right? So this patient does not have an immune deficiency. I don't need to see what the immune deficiency labs show. And, these patients, if you check them, may actually end up with some lab abnormalities because they're getting steroids all the time. What they really have is asthma that's undertreated and allergies that are undertreated and probably a migraine or a primary cephalgia syndrome, right? And so I always want to stop and think about that. You'd be amazed how many times just treating their asthma, their allergies, and their sinus disease actually fixes a lot of their infections for the patients with the milder immune defects. So I just stop and think about, is there anything anatomic, anything allergic, anything inflammatory that could be leading to these infections and predisposing them that I haven't already addressed? All right. So in this patient, I would say step up their asthma therapies, step up their allergic rhinitis therapy, and try to treat their migraines, and then have them come back before you do anything else. So first step of the ladder. All right, what do you do after you've done that and they're still getting sick? So early antibiotics, right? So this is something that I know kind of goes against a lot of what PCPs like to frequently are taught appropriately, which is antibiotic stewardship. To set the background up for this, I want to tell you about one of my favorite studies. It's called the Big Love Study, the Better Identification of Germs Longitudinal Viral Epidemiology Study. So this was a really cool study in Utah, where they took 26 households made up, they were large households, 108 individuals, and they swabbed each individual's nose every single week for the entire year. And they took symptom diaries. And then when they took on the nasal swab, they did a respiratory viral PCR. And so they looked to see how often did you have virus in your nose and how often were you symptomatic from that virus. And this is really the money slide. So the reality is, depending on how young you are and how many children are in your household, that people can be sick or have positive virus in their nose almost all of the year. So that's 87% of the year, right? So the reality is that especially if you're talking about children, but even in adults who live with children, the most likely cause of a respiratory infection is probably viral. I get that. And so what I'm about to say is going to go against everything you've been taught, which is that you shouldn't prescribe antibiotics for viruses and that most infections are viral. I agree with you on both fronts. But what I'm going to propose is that these are patients that are a high-risk population. They have an immune deficiency. They either have a low IgG, a low IgA or IgM, or they have an impaired response to vaccines. So they're at higher risk of having a more prolonged infection or a bacterial superinfection. So for these specific patients, I would propose, even though we're probably treating some viruses, that we give them antibiotics early. We don't make them wait 7 to 10 days to see if their symptoms get better. Just go ahead and treat. You may give them a little longer. So if you would normally give 5 days, might give 7 or 10 instead of 7. Maybe give a broader spectrum antibiotics, go for something like augmentin instead of azithromycin, something to cover more pathogens and resistant pathogens. And for those of you that are in rural areas where the pharmacy may not be open at night or on the weekends, or where there's poor access to care, they may have to drive an hour to see a physician. So that even coming in to get that prescription for those early antibiotics is practically impossible. If it's a reliable patient, you could even consider giving them some antibiotics to have on hand at home so that they can take that early in their course. That's a strategy I've used in quite a few patients, and it's actually remarkably successful, and you'd be surprised. Patients are actually fairly restrained in using these. What I do is I don't give them refills, and so I know when they've used that antibiotic, and I can kind of get a sense of the cadence with which they're using those antibiotics. And if it's all the time, then we need to talk about what's going on. Okay, the next thing, prophylactic antibiotics. So this is the next step up. If they're getting early antibiotics all the time, then what you don't want is for them to just be chasing infections. You're going to try to want to prevent infections. So this is the concept of giving people antibiotics every single day for either the the fall, winter, and spring, with a break for the summer, or year round, depending on the seasonality of their illnesses. Frequently I rotate those antibiotics. I'll show you what that looks like in a minute, like between 2 or 3 different antibiotics. That's no data behind that. That's just my practice. The idea behind that is if they're going to be on antibiotics all the time anyway, chasing infections, that if you use a low dose of a relatively narrow spectrum antibiotic on a regular basis, you can prevent them from having so many breakthrough illnesses and improve the quality of their life. Again, this has been studied in a really well-done trial. This is in patients with common variable or X-linked A gammaglobulinemia who were already on immunoglobulin replacement, but who still had infections. And they randomized them with a double-blind placebo-controlled trial to either getting azithromycin 3 times a week or placebo. And they followed them for 3 years. So a really robust study design. And if you look here, exacerbation-free survival is amount of time that they went without having an infection. The patients on azithromycin compared to placebo did do better. They had less infections and they had less hospitalizations. So it worked. And more importantly, for what you guys are probably all thinking, it did not cause resistance. So they swabbed the patients' noses of those that were on placebo versus those who were on treatment to see if there was a different microbiome or a different rate of susceptibility to the azithromycin, and they did not see any difference between the placebo and the treatment arm, so it did not cause antibiotic resistance. And I'm sure you guys are also worried about GI side effects. It did not cause GI side effects. In fact, if anything, they were more, although not statistically significant, number of GI AEs in the placebo arm. So remarkably well tolerated, effective, low cost, and really does improve the quality of life. I have many, many, many patients on prophylactic antibiotics with great success. This is just an example of the regimens that I use. So there's lots of options. If I usually, as I said, my practice is to pick 3. For example, amoxicillin, Bactrim, and azithromycin, rotating 1 for a month. The next month you switch to the next one, and then the next one. If they don't tolerate one, I can substitute in a different one. Or you could just use monotherapy. If I'm going to use monotherapy, I most often been using azithromycin. But you could use any one of these. There's, again, no head-to-head comparison that one's better than another. But I really like to try this in many of my milder immune deficient patients. And again, I've had great success over the last decade and have yet to have a single case of anecdotally C. diff or resistant bacteria emerge. So absolutely worth a shot. And then the last step of the ladder is immunoglobulin replacement. Now, again, I would say it may be intimidating if you're not an immunologist to be prescribed immunoglobulin replacement, but I just wanted you to become familiar with it, because where you may end up is a situation where you're managing the follow-up, meaning an immunologist starts them on therapy and you're following them, or maybe you're going to prescribe it on your own. Either way, just to kind of know the terminology. So immunoglobulin replacement therapy is the broad term that we use for the IVIG, which I'll get in, and then sub-Q IG. And so all of those are called IGRT, or immunoglobulin replacement. Broadly speaking, what this is basically passive antibodies. So they pool paid kind of professional volunteers from the United States. And they take anywhere from 1,000 to 60,000 donors. So it's a huge number of people. They take their plasma, they pool it, they purify it, test it for pathogens, remove all of the IgA, M, and E. So that's a common misconception, is people think that if you have IgA or M deficiency, we can fix it with IVIG, and you can't. You really only can get the IgG. And then they administer it to patients. So a few points is that the manufacturing process takes 9 months. So this is the average antibodies against common pathogens in the United States that an average United States resident might have. It does not have antibodies against the latest seasonal viruses because those weren't around 9 months ago. It doesn't have antibodies against emerging pathogens. Like at the start of the pandemic, there were no antibodies against COVID. Now it does have a high titer of COVID antibodies, but it didn't before. And it also doesn't have antibodies against weird or unusual or tropical pathogens, right? So these are the things that the average Joe on the street might have antibodies to. In terms of how it's given, it can be given intravenously once a month. Usually that's at a hospital, but lately it can also be given at home. Or there's sub-Q, which is given by the patient or their family member at home, which allows a little bit more flexibility for dosing. So they don't have to take time off work. They don't have to worry about if they're on vacation. They don't have to worry about bad weather. And so there are a huge variety of options that really allows you to tailor therapy for what fits best for your patient. Not advertising any one of these products, is just to give you an idea of how many different products there are available. And again, the choice of which one to use is really based on whether they want IV or sub-Q, whether they want to infuse more or less frequently. The dose that you're trying to get sometimes is not feasible based on the route, which product, if there's one in particular that they don't tolerate or do tolerate. And a lot of times it comes down to whatever your insurance will cover. It's just the reality of it. Does this work? Yeah, it works. So unsurprisingly, if you give people IVIG, same thing would be true for sub-Q IG. You take their IgG levels from wherever they started and you increase them in a dose-dependent way. And when you do that, the rate of pneumonia goes down proportional to how high you boost them. So it's a very effective way at preventing serious bacterial infections in your antibody deficient patients. There's a concept that the amount of IVIG you need to give a patient is very patient dependent. And so if you have a patient who's been started by another physician, say, and you're managing them longitudinally, or if you are the one who's managing it primarily, just be aware that numbers are not the whole story. Some patients need a level that's higher than other patients to maintain health. And so you can sort of adjust that dose up and down depending on how your patient's doing. And in terms of how it's tolerated, it's actually very well tolerated, especially the sub-Q form. It's really local infection reactions. Very rarely anything systemic. IVIG has some rate of adverse reactions, but they're usually flu-like symptoms, headaches, fevers, chills, and there's all sorts of tricks that you can use to get patients to tolerate. It's rare that you have a patient who you can't figure out how to get comfortable on IGRT with enough adjustment. And that is it. So I promised I would leave time for questions, so I did. So I've gotten 9 minutes, and I will pause my share and open it up if anybody has anything that they've encountered in their practices, anybody or questions about anything I said.
Right. So if no one has any questions, we'll go ahead and just end our meeting today, but I do have a few things to review. So now on our ECHO homepage, you will see a discussion board. So if you have any kind of discussions, any kind of questions that you have, You can reach us during the week through the discussion board. And I'm also going to send out our email and a survey. So in the chat box, you will see a survey link for our echo session today. And go ahead and fill that out because it tells us what we're doing good at, what we need to improve on, and give us some suggestions on what you want to hear from us in the future. And then I also put our email on that. That's how you can get in touch with us if you have any case studies you'd like us to go over, any kind of help that we can support you with in your practice. Just don't hesitate to reach out.
Thanks, CJ. It looks like Dr. Ryder had a question.
Hey,
Oh,
thanks,
I didn't
Dr.
see your
Law.
hand. I'm sorry.
I put it up late. It's my fault, not yours. And I'm going to put it down since you recognize me. Thank you. Dr. Lawrence, fantastic as always. I've had a few experiences where, fortunately, I've had a great primary care colleague, and my patient has lived at quite a distance from me. So, and when I was practicing in Texas, this happened frequently. For example, they might come for 3 to 4 hours away, just because there was just not an immunologist in their community. And I found that the direct connection to the primary care doctor on so many levels, whether it's, hey, I need someone to really be able to lay eyes on this patient because they're 3 or 4 hours away, they're on immunoglobulin, but they sound sick. This is a very informed family. And have had really tight collaborations with, pediatricians, internists, and family physicians. And that's really made a huge, huge impact for these patients. I wondered if, you could even maybe share some of your experiences around that, or if you have any kind of pearls of wisdom that you could share in terms of, connecting with primary care colleagues and, where that's worked or maybe where there's been challenges.
Yeah, and if any primary care colleagues want to speak up from their perspective, I'd welcome it. What we're recommending with the early antibiotics is usually where we get the most need for communication, because again, it goes against all teachings of antibiotic stewardship, right? Like, I want you to overtreat every virus with antibiotics, right? And so I get why that's maybe sometimes surprising. And so I try to send a letter, or if I can call and explain, and I find that really paves the way for a good partnership. Usually with that direct communication, my primary care colleagues are more than happy to put that in the patient's chart. I'll often give the patients a letter to take with them when they go to an urgent care, because sometimes their primary care is not available and they're seeing somebody else. So their PCP may be on board, but the ER, the urgent care, doesn't have access to their chart and doesn't realize that this is what I recommended, and then the patient gets frustrated. So if there's any PCP colleagues who've gotten a letter like that and who've thought I was nuts, I'd love to hear that, or who would welcome that. I mean, I'd love to hear any input about how we can partner better. Or if anybody's listening to this and on recording, because I know everyone's schedules are busy, you can feel free to, like Angie said, communicate with us that way. Again, the goal of this is to develop a partnership. So we welcome any kind of feedback or communication through that method as well.
Yeah, I do love the idea of a letter. I think sometimes, and sadly, these patients will often have difficulty, as we all do, whether we have a primary immune deficiency or not, like late night, weekend. And so folks will need to access a urgent care or an emergency room after hours by someone who doesn't know them and maybe doesn't know, or isn't familiar with their condition. So I think that has been a strategy that's been really helpful. For example, I've had patients that have had hereditary susceptibility to, say, meningococcemia. And so in that situation where they have a primary immune disorder with a, open kind of pathogen portal to, a microorganism that can be rapidly fatal, I will give them a letter or, a PDF or something like that. And it'll have my information, my contact information, but then also just like a really structured, bulleted, very, kind of straightforward thing like, IV Levaquin, stat, I mean, just, something that will be life-saving, and then kind of shoot first, ask questions second. And I've heard back from colleagues that has been helpful, that it kind of demystified the situation, and then they felt that the patient of course was appreciative, but also that they felt like they were doing right by the patient, and then they could kind of say, okay, what is this disorder that I heard about as a second year medical student, but haven't thought about it since.
Yeah.
Which, when you're on the front lines, you aren't necessarily going to be thinking about these rare disorders at all times. But so I love your idea of having a letter, giving that to families. And personally, I've found that to be very useful, and I've heard from families that they've been appreciative, as well as colleagues who are seeing these patients nights and weekends.
Yeah. Yeah. Thanks for sharing that and validating that approach. I also wanted to mention, if you were attending live, I did go fast through the doses, but the slides, I'm about to upload them as a PDF. So if you want those doses for the prophylactic antibiotics, that'll be available to you as well. So Angie, I think we're at time now. If no one's thought of anything else, I guess we can probably wrap up. Is that fair?
Okay, that sounds good. Does anyone have any other questions?
All right,
Okay.
thank you.
All right, thank you guys for attending. And like I said, please fill out that survey and email us if you have any questions.
Thanks, everyone. Monica,
good
thank you
week.
so much.
You're welcome. Thanks, Dr. Ryder. Thanks, Angie. Bye-bye.
Oh, you better call me Nick. Come on. And that's on the recording, so that's perfect. Great job. Thank you.